Hey, everybody. Welcome to episode 3 of the Rebuilt Plus podcast. My name is Jake Souva. I'm a doctor of physical therapy and the owner of Souva PT Performance. Today, we have Dr. Ben Mayo with us. Dr. Mayo has been a great resource for us in the community to be able to send patients to work with. And honestly, I feel like our relationship with him is exactly what I believe a physical therapist relationship should be with the physicians and the surgeons. We've built a good relationship, and the patient, us, and Dr. Mayo, it's a good team of 3. So I wanted to take time for you guys to meet him, learn a little bit about him, and see how awesome he is. So Dr. Mayo, tell us a little bit about your background and what makes you interesting.
Yeah, thanks, Jake. No, it's great being on. It's been great getting to work with you and share some patients. I think, like you said, it's a team thing. So having those direct relationships and contacts, to be able to send patients back and forth, whether it's someone you've seen that you're working with and ends up with an injury, or they're trying to rehab and it's just not getting better, and then on my end, patient gets an injury, I can get them into a PT quick or get them started in post-op rehab quickly. And, as someone who's evidence-based and knows how to work with the athletic population, it makes a huge difference. So, a little bit about myself. I'm an orthopedic surgeon who is specialty trained in sports medicine. I did a fellowship out at University of Connecticut for that. Got to work with the teams and the athletic department and team physicians there. But before that, I guess going back to the beginning, I was born here in Michigan. I born out in Ann Arbor, lived here until I was about 8, and then moved over to the Chicago suburbs. Dad got a job out there and grew up there as an athlete growing up. I played AAA hockey, so I was always back here in Michigan to play against Little Caesars, Honey Baked, all those teams. And then, I played lacrosse too. So that was kind of what I focused on growing up, and eventually got recruited to go to St. Olaf College out in Minnesota. Went there after I played a year of junior hockey in Dubuque, Iowa. I was originally a exercise science, or I was an exercise science major. I was thinking of doing something like physical therapy or strength and conditioning. So, this kind of field is kind of what I've been learning and focusing on since college. And, I guess you could say even while I was playing sports, I had a big interest in fitness. I can't say I was the most skilled player there was, but I knew if I could work hard and be in shape, I could do something out there. So, I was the exercise science major, biomechanical medical studies concentration. Like I said, I was thinking about becoming a strength and conditioning coach initially. So I did actually get my CSCS degree, which I never ended up using because I went to medical school right after, but I got it. So, I kind of at least have some knowledge of the types of things you guys are doing, and people who are in the, workout community or weightlifting community. I have a good understanding of the types of things they're trying to do. And then I went, back to Chicago for medical school. I was at University of Illinois Chicago down there for medical school, and then also my orthopedic surgery residency, which was an additional, 4 years of medical school, 5 years of residency, and then I did my, 1 year sports fellowship for additional training. Focusing on working on the athletes, particularly, with some niche here in pediatric or adolescent athletics at the Connecticut Children's Hospital. So that's kind of where my niche is. It's sports medicine, which is kind of a misnomer. It's not just people who play sports. It's the active population, whether they're 12 or 30 or 60 or 80. I do things all from ACL surgery, patella instability, meniscus surgery, rotator cuff repair, shoulder replacements, shoulder instability. Those are kind of the big things, probably the most common things. And then, because it is things that athletes do, it's ankle sprains, Achilles ruptures, elbow injuries, Tommy John, get a little mix of everything. So it's an area that I like because you get to see all sorts of things and work with all sorts of different populations, and people are pretty motivated to get back to do the things. I'm happy to help them do that.
So you said it was 4 years of undergrad and then 4 years after that with residency.
So 4 years of undergrad, 4 years of med school, 5 years of orthopedic residency, and then a 6th year, that additional year for fellowship. So,
geez,
4, 9,
14 years.
And I actually did an additional year during medical school to do a year of research in orthopedic surgery to kind of further advance knowledge in my curriculum. So it was a long time even after college to get here.
Yeah. So by the time you're out on your own, done with all that. You're what, 30,
Yep.
33 probably,
30.
or maybe
Yeah. So I had
32?
some time after high school, before college, to play hockey. So I was a little delayed. Most hockey, or a lot of hockey players do. Doing the playing juniors. So yeah, I was I'll say 35 when I got my first real job.
Yeah. And when was that? What year would that have been?
So I finished fellowship in 2023. So I got a fellowship in Connecticut, came here and started the job over at Synergy Mental and Orthopedics, and been there since.
Okay. And then I think in our communication you said that do you have kids?
Yeah, so
Or no?
I
Yeah.
my wife Caroline. She's from here, Troy, originally, and then we met out in Chicago while I was in medical school. She works in tech. So yeah, she's been with me and very supportive. And then we got our two daughters, 5-year-old Mia, and then Amelia. She was born on New Year's Eve, so a little over a year now, going up 13, 14 months, 14 months, 15 months.
Okay. How is that with I asked the last person who was on, she was a gym owner, she got kids. I'm always
Yeah.
curious, how is your profession with being a father? Like, is it easy,
Yeah.
hard, or
So
what?
so now that I've made it out the other side, I got a little bit more control over my schedule, and the most of orthopedics now, it's not, there's not major emergencies that need to be done. I still take call, and there's times on weekends I'm working, but for the most part, I've got a pretty good control of my schedule where I can take daughter to school in the morning, be around to help. Surgery days, they start earlier, so I got to get out pretty early. But yeah, I mean, it's not quite like training when you're on call all the time, real early mornings, late nights. That was a little bit tougher, where you could be working 60, 80, 100 hours in a week. Now it's a little bit more
Jeez.
a little bit more reasonable.
Yeah. Okay. Like, out of that 14-year span too, like, which part was like the best, and which one was, I guess, like the most trying of that?
Yeah. The hardest, I think, probably universally in orthopedics, is the second year of residency. That's kind of when you've been around enough where you have some knowledge, where they kind of trust you to make decisions on your own. You're in the hospital alone overnight, taking call at the trauma centers. But it is the first time you kind of have that responsibility, and having to have trust your knowledge, where there's no one like there to bounce it off of. It a car accident comes in at 2 a.m. It's you, the one kind of managing and stabilizing. And obviously you can always call in, but you got to trust your training and trust your knowledge. And it's just, the younger you are in the residency, you are expected to take a little bit higher brunt of the call. So you're on call more often. That's where, you're in the hospital for 24, 30 hours at a time, to seeing all the consults and managing all those things. So yeah, that's probably the hardest time. Just, it's the longest hours. It's the toughest, as far as, your knowledge compared to your responsibilities.
Did you
And
say
then
24 straight hours?
yeah, that's usually how
Yeah.
most places do it. Yeah, you get there in the
Oh,
morning, you're on there till the next morning, till the next side comes on. There's other hospitals they do it where,
wow.
like, you're on for a week of nights in a row. It all depends on the place, but ours was typically yeah, you just take your 24 hours of call, you have the next day off, and then depending on the year, sometimes it's every third night, every fourth night, every fifth night. I was doing stuff like that, and then I think as you get further along in residency, you have a little bit more autonomy. You are less expected to be in the overnight calls. It's a little bit more of a relaxed schedule. So, and then fellowship is the best. Sports, we're not taking any call, at least in my program, where you're, that's pretty well oiled, efficient machines at these academic centers, where you get there, you do a bunch of surgeries, and you're still home, you know, late mid afternoon, 3, 4, 5 o'clock at the latest.
Yeah. So you said that was the best. The best part was the fellowship. That was the best part of the experience.
Fellowship, yeah. I mean, it's you go to fellowship because that's the area you're most interested in. So every day is just doing the stuff that you like and you're interested in. Whereas in residency, you do things that maybe I'm not as interested in. Hand surgery, spine surgery. People like those
Yeah.
things. Wasn't for me. So you got to do the stuff that you're not as interested in, which is fine. It's still cool. It's doing surgery. It's there's benefits to understanding the other subspecialties, but yeah, it's when you're only doing the stuff you're really interested in, it's a lot better.
Do you have a surgery that you like to do the most? Like,
Oh
your
man,
favorite?
I mean, kind of like those big six ones I talk about. ACL surgery. That's kind of like the the bread and butter of sports. So I love doing ACLs, love shoulder replacements. I really like the patella instability, which I know a lot of people don't necessarily like. So it can be a complex problem, but I like doing MPFL reconstructions, osteotomies, things like that. I think they're fun.
Yeah, I remember like when you came to Umbra and we were talking a little about the MPFL, and you were
Yeah.
saying about the I forget where you said they were doing it with, like the dye, where they were able to see like the exact. You know what I'm talking about? Remember our conversation there? It was like
Oh, like
some advancement that they were doing. That was pretty interesting.
yeah. So I mean, the anatomic like models where they figure out the exact anatomy of where these ligaments attach and how to best recreate them. There's some places that they're doing pretty cool, like anatomical dissections to be able to identify these and help guide how to best do the surgeries.
Yeah. What would you say? What would you say in terms of like ACL? Like, are you more of a fan of the quad tendon, patellar tendon?
Yeah, so
Ham-
I think there's a time and a place for all of them. They all have their strengths and weaknesses, and it all depends on the specific patient, what their goals are, what they're trying to get back to. Different factors, like patella tendon. It's a great graft. It's the gold standard. That's essentially what every NFL player gets. That said, not everyone is an NFL player, and there's some risks to it. It's a bigger scar. People do have concerns about that. That's it's not a silly thing. People don't like scars sometimes. Risk of some, there's a scar right on the front of your knee, and if you have a job where you kneel a lot, or the religion where they kneel a lot, that could bother people. So that may not be the best choice for them. So I'm happy to do basically any graft. I give people the options, and they kind of decide the things that are important for them. So I think the two most popular these days are the patella tendon and the quadriceps tendon, at least for surgeons that are more recently trained. Nothing wrong with hamstring. Again, there's a time and a place, but at least my population, those are the two most popular. Allograft can be an option for the older patients. Once you get above 35, 40, say older, it's like, you see the 34-year-old pro athlete. Oh, they're ancient now.
yeah.
But yeah, there's an option for that too. And there's benefits. It's easier recovery, maybe a risk it could re-tear a little bit, but if you're not doing high risk things. And then also the other thing that's a little bit newer and I think has good potential, and I do it in a lot of patients, is the ACL repair with the Bayer implant. If people have heard about that, where we actually do stitch up your own ACL and reattach it, and then add some biologic augment to get it to heal better. And people can do really well with that. Like I said, in the right person, it's a great surgery. It's easier recovery. Yeah, I wouldn't do it in a 16-year-old who's looking to go play D1 soccer, because there is some increased chance it could re-tear, and they're a really high risk population. But yeah, there's a lot of good options.
Yeah, and we see so many ACL patients at our clinic, and hopefully they can hear this right now. But if you had to say one thing, or at least maybe even a couple
Yeah.
things that you've seen where patients end up re-tearing, is there a common denominator that you see with some of these patients?
Yeah, so I've been fortunate that I haven't had too many of my own have to re-tear, but I think the things we know from the literature, there's things that are risk factors, and I think one of the biggest things now is that you can't just say, oh, you're X number of months out from surgery, you're free to go. It's a lot more nuanced than that. Additionally, I think previously say, oh, 6 months, you're good, go back. We now know that every month after 6 months you wait, you reduced your chance of re-tear by 50%. And if you come back before 9 months, you get a 7 times or higher chance of re-injury than someone who waits longer than 9 months. So for all my patients, I tell them it's a 9 month minimum. That's the earliest I'll
Yeah,
let you go back. Longer is probably not a bad thing, because it does give that graft longer to turn into a new ACL and get strong enough. At about 9 months, it's about 80% as strong as it's going to end up being. And that last can actually take up the full 2 years after surgery until it's done remodeling. So that's the first thing, is we got to wait longer. I know everyone wants to get back, but it's not in your best interest. And then the other thing is where you come in. I always tell patients, I do the easy part of this whole process. My part takes 70 minutes or something like that, 90 minutes if there's some meniscus work or it's a complex one. The patient, they've got the hard part, because they're going to PT 2, 3, whatever times a week for months and months and months on end to get that strength back, and making sure that you have the strength, you have the functional ability to perform your athletic needs to make sure you can land safely, change direction safely, do it confidently. There's a mental aspect too, which I think is really important. Having confidence. If you're going out there, yeah, okay, I passed all my tests, but you just don't trust your knee, you're going to put yourself in compromising situations and get yourself a chance of re-injury. So there's a lot of factors. And, I think the simple ones are the time and the therapy assessment, the return to sport testing. Those are the two most important. There's some other things that are just out of our control. Some people are, they're bony anatomy. They're more, knock-kneed than others. That puts you a little bit at risk. We're not going to address that unless it's totally abnormal for a first-time patient.
Yeah. When you say about the timeline, when you think about, like, when you said 6 months saying, hey, you're just good to go, like most patients, I feel like when we do our strength testing at 6 months, I mean, I'm not seeing really anybody that's even much north of 80% symmetry, at that point. And for us to send them back,
80% of the 6 months is a really good outcome at that point, I would say. And some people who are lagging behind that, which it's not abnormal. You're not there yet. It's fine.
Yeah. I feel like quad tendons in general are the ones that just struggle a little bit more with the quad strength, which
they certainly can.
Is fair.
Yeah.
Yeah.
But right near that muscle, I'm sure it gets a little bit aggravated.
But yeah, I mean, like, it's weird though. I feel like at around 9 to 10 months, like really things do start coming together from a strength aspect too. We can change very minimal about their program, but it's funny how you just exponentially see the asymmetries getting better. So I think those numbers that we can see in the clinic compared to the numbers in the research, it's just very interesting how they correlate so well. And I'm with you. I'm always like day one, like, hey, I'm not clearing you before 9 months. So you can do what you want, but you're not getting that clearance from me. So
no, I think the other thing people need to realize is they always look at, so-and-so pro athlete, they came back in 9 months. You got to realize they have unlimited time, unlimited resources, the best resources. Their full-time job is recovering from whatever surgery it is, whether it's ACL, Achilles, things like that, or, the patients, you got real things to do in your life. You got to go to school, you got to go work, you're not rehabbing, recovering, training. 16 hours.
Nutrition too, right?
Yeah, nutrition too is a huge part of that. That's another thing I didn't talk about. I got some partnerships that I work with where, try and optimize nutrition preoperatively. It has been shown to, decrease the muscle atrophy that occurs after surgery, enhance wound healing, things like that. So, yeah, it's certainly an important part and something I discuss with my patients.
Yeah, it's such like a holistic piece, of just looking at every little aspect of the recovery that I think a lot of patients do miss. They don't think about the sleep and the nutrition and all that. So the more that I guess we can, educate them on that to the best of our abilities, or at least get them to those resources that are going to be, experts in that field, I think that's definitely where it's a nice complementary part of our team.
Yeah,
for sure.
Absolutely. Like I said, it's all about the team effort, like we talked about before. Everyone's got their role and guide the patient to do the best thing to get them back as safely and as quickly as we can.
Yeah, absolutely. So, okay, being in the gym, I see patients constantly who have shoulder pain with bench pressing, and I just want them to hear some things from you of, like, for these guys who are trying to, bench max effort all the time, like what are some shoulder health tips that you would have for them that they might have heard from me and not have, taken it to heart, but then if they hear it from a second person, maybe that'll be it.
Yeah, I mean, I'd say far and away the most common thing that I see in patients, 20, 30, 40s, even into their 50s with, heavy lifters is biceps tendonitis. They get that pain in the front. Obviously, as you get a little bit older, you run into more of the rotator cuff issues. And some of that is just a metabolic issue. Some of it is, putting heavy loads through it. I think the biggest thing for most of injury prevention, whether it's bench press, squatting, whatever you're doing, is you got to have good balance to your muscles. People who are active, they're going to the gym, they come to me with pain. I'm like, all right, well, we need to get you into some physical therapy. And a common response I get is, well, I work out, I go to the gym all the time. Like, they don't know what physical therapy is. It's a little bit different though. There's more nuance where my kind of spiel is what the therapist is good at doing and what you're good at doing is you're good at assessing where the relative deficiencies are, imbalances in the muscles are, where, like most people, they go to the gym, you focus a lot on the pushing motions, the bench press, the fun exercises, right? Not a
Yeah,
lot
oh,
of
yeah.
people are working on their rhomboids or their serratus to control that scapula and their shoulder blade, because the shoulder blade is it's the socket to your shoulder. So when there's imbalances in the muscle, that shoulder blade gets in an abnormal position and other muscles have to work harder than they would otherwise need to. And you start getting irritation because something's working a lot harder. The biceps is working really hard to kind of put the humeral head in the right spot in the socket. It gets overloaded. So making sure that you have good balance in the muscles, both, like I said, almost always it's issues with the scapular muscles, having good posture, having good flexibility. What happens, what everyone these days does is we're always, hands in front of us like this. We're on the computer, we're on our phone. We go to the bench press, and then we're like, I'll do back tomorrow. These muscles get really tight. The shoulders get kind of rounded forward. These muscles back here get really weak, and it's hard to get the shoulder blades back and down to make sure you have a good posture for all the activities you're doing.
Yeah. And that's like, I see so many people too, they just jump right into it. There's no warm ups. There's nothing. It's just like, here we go. Their warm up is just a couple reps with the barbell, right? It's not like any other type movements.
Yeah. I think again, that making sure the rotator cuff gets nice and activated and warmed up, where it's some people jump into too quick. All right. Yeah. My warm was 135. You got to get get those 2-pound dumbbells and get the rotator cuff warmed up a little bit, because anything heavier than that, then the deltoid, the pec takes over, the trap takes over. So
yeah, and that's another thing. Like, I'll see people, they got the plates, they're holding them here, and they're doing this, right? And it's like, I've made so many videos on it. I've told people, I've gone up to them, hey, like, I don't want to be that annoying guy, but I will just recommend maybe you use a band, maybe you switch up, lay on your side, right? Yeah. Just something that's actually going to work the rotator cuff, because right now you're just doing a little bit more bicep isos.
You're just cooling down the rest of the gym by a fan in the air.
Yeah, but I'll tell you, I see that done so often. That is the biggest one that I see. And then really, I think people just bastardizing the crap out of like the external rotation exercise, just using a band that's way too heavy. And like you had just said, they're using everything else.
Yep.
So
exactly. Yeah, you gotta check your ego a little bit sometimes to get the small muscles to let you get to the big muscles later.
Yeah, absolutely. Absolutely. So hopefully if you are an Umbra goer and you hear this right now, that you're gonna take this advice, because this is me.
You're gonna end up in my clinic.
Yeah, right. Something that a lot of people probably don't know, which I always find super fascinating, just the idea of a reverse total shoulder versus a regular shoulder replacement. You want to explain that for some people here real quick? Because I think it's a really cool thing that they've come up with.
So, the indications, typically for any type of replacement, knee replacement, hip replacement, it's arthritis. And predominantly for shoulders, that is still the issue. People get arthritis, you replace it. That's really the only surgical cure for arthritis at this point. That said, there are issues that you can have that don't allow you to do just a regular replacement sometimes. So there's two main types that we do. We talk about an anatomic total shoulder replacement, where you got the ball and you got your socket. So in an anatomic meaning how you're built, we cut off the ball and put a metal ball, kind of grind away the socket and put a plastic socket. So it's designed how you are designed. That works great for if you have an intact rotator cuff, which rotator cuff tears are a very, very common problem as you get older. Sometimes they don't even cause pain. There was a study come out that once you get above 40 years old, people with no shoulder pain, 90+% of them will have something on their MRI, like rotator cuff tendonitis, partial tears. A lot of people have full thickness rotator cuff tears that they don't even know about, don't have any pain. So if there is rotator cuff issues, or maybe it's not completely torn, but it doesn't look good, it's deteriorating, you're 65, 70, 75, where it's there, but I don't love it. It could tear soon. we have other options. Or the patients who they have really big rotator cuff tears where it's not fixable anymore. I could put stitches in it, pull it back down to the bone, but it's not going to heal. The other alternative that you're alluding to is the reverse shoulder replacement. So like I said, we had the ball and the socket. In the reverse, we flip those. So we cut off the ball, and instead of putting a new ball, we put a socket. And on the socket side, then we put the ball. And what that does is it changes the mechanics of your shoulder. It changes where the rotation point is. It allows other muscles to take over for the rotator cuff that either is not there or not working well, where the deltoid and other muscles can kind of allow you to lift your arm up and have reduced pain and good functional strength, even if that rotator cuff isn't there. So it's a great option for people like that, or patients who have really bad arthritis. It's a lot easier to correct some of the deformity. So it gives us a lot of options. It's a really, really good procedure. People are really happy with it usually.
Yeah. Would you say on average, do you do more regular shoulder replacements, or do you do more of the reverse?
I do a lot more reverse. And I think that's kind of the trend, internationally, even, where because the outcomes of reverse are so good, it's a very durable surgery. It needs to be revised less frequently because if the rotator cuff tears, doesn't matter. Most people, I would say, are probably heavily reverse as opposed to doing the anatomics. Now, I still will do them, younger patients, great rotator cuff, really high activity patients. That's good surgery, but lower demand, older patients, bad arthritis, the reverse does really, really well.
Yeah, it's sweet. Is there anything else like that's kind of up and coming in the research with surgical interventions that's kind of game changing that
I
we
think
might not know about yet?
they're always revising techniques. I talked about the ACL repair, the biologic augmentation of things. That's a big factor. One of the kneecap instability issues that I address is when the groove of where the kneecap goes is very shallow. Can sometimes do what's called a trochleoplasty, where you actually kind of remove some bone and create a new groove. It's not a very common surgery, but that's kind of one that's gaining popularity. Um, the hot topics these days is a lot of the cartilage restoration. Historically, cartilage was gone, don't have any options for it, but now there's a lot of new things where you can kind of like grow the patient's own cartilage. If they have an area where the kneecap dislocated, knocked a chunk of cartilage off, that cartilage doesn't have a good potential to heal on its own, or if you stick it back, it's not going to incorporate. So we can take a sample of that patient's cartilage, send it to a lab, and they actually grow a sheet of their own cartilage and send it back to us, that we can kind of basically take a cookie cutter, make it the exact right shape and size, and kind of stick it in there, and then over time it incorporates and turns into new cartilage. So that's a surgery that can be pretty helpful in these isolated situations. Other things like that as well, where sometimes you kind of like grind cartilage up. But the cartilage restoration is probably kind of the most tech growing field that we have, where there's a lot of potential. The biologics in general is a really hot topic in orthopedics now. We talked about the ACL repair, things like PRP, stem cells, bone marrow aspirate. It's all really new. We're still learning about it and what the best uses for it are. There's a lot of things that's not useful for it that we've studied and we tried it and it doesn't work. Maybe we just aren't doing it correctly. But that's kind of where the next wave is, that, we can physically repair things, but then how do we make it heal better?
Yeah. What's your thoughts on the PRP?
Yeah. So it's, like I said, it's newer. Most studies that we've done in orthopedics have not shown any particular benefit over the things we've already had. That said, people get it sometimes. They feel better. It's great. There's not many downsides to it. The biggest downside to it is the cost. It's still, new enough that insurance doesn't cover it. And it can be several $100s per injection, depending on where you go for it. Sometimes even over $1,000. So there's things that I think it's more likely to have potential to be helpful for. Certain tendinopathies like tennis elbow, Achilles, some muscle strains. That's where I think it has more potential currently that we've seen. Things where it has less likelihood or lower chance of working is like bad knee arthritis. They've done it. Patients sometimes feel better, but when they compare it to just injecting, water or it's not different long term. So it can make people feel better. It doesn't have some of the downsides that doing like a cortisone shot would, which can actually deteriorate tissue over time. But but I don't know that's necessarily better from it's not going to regrow your cartilage. It's not going to make you not have arthritis anymore.
Do you think at some point it's going to be more, I guess, covered by insurance, or do you not, until the research would show
Yeah, I
otherwise,
think the
that
research
insurance can have a hard
wants to show
time?
it's beneficial. The research, the insurance's whole goal is to have to pay less money long term. So if they say, okay, if we pay for this injection, patients aren't needing surgery later, which is way more expensive, then they'll probably start covering it. But I don't think the research is there enough at this point to have any proof that it's doing that at any high level.
Yeah. Okay. And while we're at it, we got to bring up peptides because it's something that some patient asks me every week. And honestly, I've had so many parents that have told me that they've like given their kids like BPC 157 when they're recovering from ACL and whatnot. And usually it's, I learned about it on a podcast, and then it's, I've done all my research and you should do your research too on it, when I kind of tell them my thoughts, So what's your thoughts here with peptides?
Yes. So I think it's everything I said about PRP, but more in that it's really unknown at this point. Very, very few real studies that have been done on it, especially in humans. There's studies in animals and rats and things like that, which you can only deduce so much from how a rat responds to how a human will respond. So at this point, there's really just no great evidence of how it will work in humans or what it does. Again, like that, there's people who they take it, they swear by it. Maybe it's a placebo. Who knows? Maybe we don't understand it enough yet, or we haven't had the data to back it up. The other thing that's really important with that, you're telling like giving it to your kids. It's very unregulated, where it's not really monitored by any governing body, where the quality control of things like that, contamination, purity, those stuffs is not well regulated. So the safety, if you're going to have people who do it, you need to make sure it's from a reputable source, that you're paying attention to those types of things. So maybe in 5, 10, 20 years, realize, man, we do this and the ACL heals in 6 months and we let people go back in 6 months. We're not there yet. There's too much unknowns. That said, I think it's irresponsible to say, nah, it's not going to work. It's nothing. No one, nothing shows. We just don't know yet.
Yeah. Why do you think it is that there's just not the studies yet on humans?
Well, I think it's hard, designing and implementing any kind of study like that where there's unknowns. There's a lot of factors that go into it. It's hard to get enough patients to want that to happen. Having like a true randomized trial where you're going to get something injected in you, not going to tell you what it is. Not a lot of people are into that. And then
that's fair.
Like if I injected you with BPC and me with something, and I did better than you, you need a certain volume of patients in the study to have the power to say that there actually was a difference, and it wasn't just random chance that these 4 did better than those 4. You need dozens and dozens, hundreds of patients sometimes to see a good outcome or an outcome that's meaningful.
Yeah. I just find it very interesting, how many people are just so willing to take some of these things, But I mean, I get it. If you're in pain, you've been struggling, you're not able to work out for 6 months. I mean, it's easy to, quickly see something that people are touting, right? And just be like, I'm going to try it. But
I think everyone's interested in the quick fix. And unfortunately in orthopedics and musculoskeletal things, it's just, usually it's time and more therapy and more effort, and eventually it gets there. But there's nothing easy about it most of the time.
Yeah, I know. That's one of the hardest things about my job, honestly, is when somebody comes in and they're like, expecting me to tell them, hey, it's going to be like two visits, and all of a sudden things are going to be all the way better. We can make, with a lot of conditions, we can make good changes in weeks time, but I kind of preface it, hey, we can get you out of pain, but we can't fix the problem for, a bit amount of time. At least 6 weeks, right? For a good handful of injuries.
That's what I tell most patients. A lot of times it's a problem that's been bothering them for months to years where they've had this issue. I always tell patients good 6 to 8 weeks of therapy is enough time to say, is it helping? Are we seeing any improvement at that point? If not, then we look at other things. But that's like when patients come, oh yeah, I did PT before, it didn't help, and you dig a little further, yeah, I went 3 times. That's not enough to see any kind of change. You gotta put in a good effort, 6 weeks, a couple times a week to kind of start seeing some improvements. And sometimes it's longer. It's like anything else. You're going to the gym, you're working out. You don't just go 3 times and suddenly you're benching 315. It's years of consistent weightlifting to make any muscle stronger, that's what therapy is doing. You're getting stronger with these different muscles.
Yeah. And that's like even with some of our programs, versus just trying to get people in 2-3 times a week for, 6 weeks. We'll try to frame it in the beginning. Hey, this is going to be a 3-month program together. We're going to be working. You may not even have as many in-person sessions. You might just be once a week, but then I write up your program that you're going to go do on your own.
Yeah.
So this, explaining to them how important that strength training is. But then we can actually take away some of the visits and not need as much, because in a lot of cases, especially I know in the insurance heavy model, they're getting people in so much because that's the way that they're going to get paid. Right. Yeah. So like the more you can come in and then, getting that volume up. But for us, if it's like, hey, we're going to look at the outcome and just be like, our 3 months together, this is what it's going to be. You're going to have maybe 2 times a week in the first couple of weeks, but then we're going to spread that out because of that strength training, keeping that eyeballs on you with the communication. And we found that to work really well, just as much as getting people in, 2-3 times a week for 12 weeks. We could still get those results for people as long as they're actually doing their stuff on their own.
Yeah, that's the other thing is, they get into the PT, which, it's great. It's, 45, 60 minutes, a couple times a week, but that's a lot of time where you're not with the physical therapist, whether it's you or wherever else they go. You got to do the things at home every day to get better.
Yeah, I always frame it from like, we have 3 hours a week together. This kind of helps push you along, maybe a little catalyst to get the ball rolling more. But then everything that you do there, that on your own, that's where I can tell, if you're actually doing your homework or not, is when you come back in. 100%. Are you making that progress?
Yeah. You're spending some of your time to assess and guide. All right, we've gotten this area more flexible, but this area is still lacking. So you're making the adjustments those times you're there. Then they got to work on them on their own past that.
Yeah.
So.
Yeah. And, because we have a lot more time with patients too, I think it does help with just that education piece to get them to buy in that, okay, this is important. That's one thing. But then on top of that, just that the patients that we usually see are more highly motivated anyways. So you tell them what to do, they're going to go do it. But
you got to benefit, being in kind of the population you target and work with, and being in the gym, that a lot of yours certainly are more motivated, or they understand, what that type of work looks like. They've done it with sports growing up, and some people, that wasn't their thing growing up. They don't really understand the commitment it takes some time to make these physical changes.
Yeah, that was one of my problems that I had at like one of my general orthopedic clinics that I worked at, was just like, when you get those patients in there and you're trying to explain to them how important it is to strength train, and they haven't touched a weight in like 35 years.
Forever.
And they just want you to like massage their way out of pain. Mm-hmm. It's like, I remember I would have so many patients, can we just do the massage today? Can we skip the exercise? And be like, this is not what we're here for. And I was like, this isn't going to make you better.
It does feel good. It makes them feel better then, but you got to fix the reason that pain is returning.
Yeah. And I know that for a lot of PTs out there, like that's a big frustration that just burns them out, when we can't care more than the patient wants to, when they want to get in terms of their recovery. So, kind of having that equal, hey, I want to get better and I'm going to help you get better on that same level. I know that at least has been a huge thing for me. And I'm sure it is too for you in the clinic, like seeing patients who come in and depending on what they're motivated to get back to, I'm sure that plays a big part in their compliance.
Part in all the decision making, whether that's, deciding to go to surgery or not, the things they're trying to get back to. Sometimes it's just not worth going through the big rehab process to overcome whatever issue they're having. And sometimes, a lot of times, most of the time, 95% of the patients I see don't get surgery. So.
Yeah, I think that's probably a big misnomer too, right? Is that people think that, if I go see a surgeon, he just wants to do surgery right away.
Yeah, no, I'm happy to do surgery on people, but no, I think most of the time I say this needs more time, this needs more PT, sometimes an injection, sometimes some anti-inflammatories, but it's about about only 5% of the time I see someone is are they getting surgery from me at least.
Yeah, and that's a much lower number, like I said, than I think most people would believe. So
Yeah.
it's good. All right, well, kind of rounding off in terms of the medical side of things.
Yeah.
What you said you played hockey earlier. Are you
Yeah.
still playing any hockey, or are you
Yeah, I
fully
tried to.
retired?
I was skating over at Buffalo Wild Wings in Troy for a little bit, and then that team they didn't dissolve. They moved to another rink because of some paperwork issues. But yeah, I still try and skate once a week. I can skate. I had to give up lacrosse a while ago, a little too risky on the hands, unfortunately. So a lot of
Yeah.
golf these days, a little bit safer. Try and get to that when I can. So yeah, no, I try and skate, try and stay active, but yeah, it's tough sometimes as you get the family things and, it's depends on the night. I'm not going to go out and play a 10 o'clock, 10 p.m. hockey game when I got to get up at 5 to go do surgery on people the next
Yeah.
morning. Not responsible for anyone there. So
Yeah,
yeah,
I
no,
know
I
that's the
got
worst thing about a lot of these leagues for these sports. I play a lot of flag football, and it's like the one league over Oakland Yard. They wanted to play at like 11 at night, and be like, okay,
yeah,
so game's done at 12. I get home at 1, and then I'm still amped up, so I won't go to bed till
right.
2. It's like I
Yeah,
love
yeah,
flag football, but come on, guys, who's
yeah,
doing
it's,
that? And they fill it up. People play, So
yeah.
hey, more power to them. But
Same with beer league hockey. It's some late nights sometimes, but yeah, I gotta pick and choose my battles there.
what position do you play?
I was a defenseman through most or all of my career, basically, until I got to men's league. Then I tend to play forward more now, so I'll play whatever.
Okay.
Depends on the night and where we need guys. I'll jump around, but yeah,
Yeah, that's one sport I never got into. I can't even skate, so that doesn't help. So
it usually is required. Yeah,
yeah, but I've heard some guys pick it up a little bit later in life too, but I don't know. I feel like I'm too far behind the curve
yeah.
now. I'm 30, so
If you're gonna pick it up late, you gotta probably already at least know how to skate.
all right.
It's tough
Oh
to pick
yeah,
up the skating late in life, but
yeah. So all
I don't
right,
know.
so we'll rule that one out for me. I can't golf either. I'm an awful golfer. I still got a terrible slice from baseball. So
Yeah,
uh,
baseball players and golf, it tends to be tough to break some habits to a very different motion. You got power, you
yeah,
can swing it hard, but
yeah.
yeah, keeping it on the planet is another
And
issue.
it's funny because with the slice right, if I try to fix it and I go left, because that's actually instead of fixing it, I just compensate, right? So I try to rip it left, but then it just goes left. Like
Yeah,
as soon as I want it to go right, it's crazy how it works like that. The ball knows.
the
I'm an awful golfer, so
yeah,
you won't catch me playing much.
get
So
some lessons figured out quick. Yeah,
that one I can take
it's
up.
like therapy. You just got to do it a bunch and work on it. So
Yeah, I need a little more money, right, to be hitting the range. But well, I
yeah,
guess with the simulators now too, that's a big thing, right, to save some
yeah,
money.
yeah. They can be expensive though. So a lot of them. I mean, there's a lot of them now, but yeah, they charge. They're popular, so they just keep up in the hourly rate.
Yeah.
We're paying it,
Yeah, so it's basically the same as going to the range, anyways.
but cheaper to go to the range probably.
Mm. All right, last little thing here. I've been
Yeah,
asking everybody this. What's your biggest piece of wisdom that you have for people professionally and personally?
man. Piece of wisdom. Yeah, I think professionally, at least in medical field, my advice for people coming up through training is that you gotta really take the time and make sure you're understanding everything that you're doing and why you're doing things. It's always question. I think is because that's how you advance in your own personal knowledge, the knowledge of the field as a whole. You don't just accept things blindly. Oh, this is how we do it. I want to be able to understand why you're doing something this way, why you're you know giving specific exercises, why you're restricting certain activities, like for post-operative therapy. Because it helps you understand things better and kind of adjust and adapt. And when things aren't going as planned, when you have a good deep understanding of things, it's easier to adjust and make corrections on the fly. Um, yeah, I think that probably kind of translates into personal philosophy too. I mean, I try to I view myself as a fairly even keel. I don't get angry at things. I don't get too overworked up for things. I think you just got to control what you can control and things you can't control, you can't let them get to you. I think one of our attendings that I worked with in residency, he was big on the Serenity Prayer. People who don't know that, it's God grant me the serenity to accept the things I cannot change, the courage to change the things that I can, and the wisdom to know the difference. Which he had some very interesting lines, but I think that was a pretty good one and helps guide life. It's not worth wasting your energy and time and things over what other people are doing. Focus on yourself, control what you can control. You can control your effort. You can control how you respond to things, but no point wasting energy on things you can't control.
All right. Dr. Mayo, thank you for hopping on this tonight. I'm glad that we could have this conversation. If somebody wants to come see you, how do they do that?
Yeah, so a couple different ways. I think probably the easiest way or most efficient, you can go to my website. That's just www.benmayomd.com. You just Google or Bing, whatever, Dr. Ben Mayo. There'll be my website. There'll be my group website. You can make appointments on ZocDoc. You can submit requests. You can call our call center. We've got clinics I go to clinic in Livonia, Sterling Heights, and Troy at various days that rotate. So a couple different locations. And like I said, I'm always happy to get people in quickly. I think that's important, especially for these athletes. Injuries, you want to get seen. You want to get things figured out quickly. So I understand that as a former athlete. So I'm always trying to get those patients in who have these acute injuries, so we can either one, get things on the path to recovery with rehab. I think getting into the rehab right after injury is important, or you get an MRI, figure out what's going on. If you need surgery, we get that done quick, so you're not 2 months down the road and then getting surgery, and then you're missing half of next season or whatever it may be. So, a bunch of different ways, and we'll get you in and get you taken care of and get you over to Jake to get rehab.
Yeah. Awesome. Yeah, and like I said, I'm very happy that we've been able to kind of build this team up. Me, you, the patient. I think it's a great thing, and I'm looking forward to everything that we get to do in the future.
Keep going with it. Love it.
Absolutely. All right. Well, hey, enjoy the rest of the night. Everybody who's been listening, thank you for listening, and we'll see you on the next episode.